So I'll start by saying something about Dr. Brenner. So it was at one of these meetings 100 years ago that I went to one of his presentations, and then had, I don't know if you remember, speaking at Jamaica through a Zoom meeting that back then virtual, and we had your slides because we couldn't do Zooms back then. And we implemented a program back there called IMPACT, Intense Multidisciplinary Primary Care Teams. And we actually still run it today through the Care Transitions Department. And we showed, utilizing the work that he showed us, a 50% reduction in hospitalizations and ER visits. And it was mostly by finding someone a place to live and food. And it wasn't really about the healthcare. So I'm Alan Roth. I'm chair of family medicine for Jamaica Hospital in Queens, New York.
Scott Conard, Converging Health, Family Doc.
Luigi Tullo, I'm the Vice Chairman of Ambulatory Care and Director of Population Health at Medicine in Jamaica.
So this program that we're doing is like deja vu for me as well. So I tell Larry I am not an innovator at all, but I am probably the first adopter. After I hear something good, I will go right after it. Not my ideas what Dr. Brenner did, and not my ideas with what Scott came up with, but it was at this meeting, the Innovators Network 4 years ago, that Scott was there from Converging Health, Michael Fine was there, I forget what you were talking about, it was something, and Wayne Jonas was there. And kind of the group of us started talking about our site and what we were doing at Jamaica at the time. So I need to set a little of the context so you know what kind of a program we are. So Queens County is the most diversified place in the world. We're 2 miles north of Kennedy Airport. We receive international travelers every day, bringing in lots of uninsured people to our hospital. Our hospital survives on public payment, so very much in value-based public payment. 80% of the hospital's revenue is Medicare and Medicaid, with the vast majority of that being Medicaid, and we still have like 10% uninsured. Or no pay. So we take care of a very poor group of people. Queens County itself is very diverse. There's wealthy communities in Queens and very poor communities in Queens. So we are the safety net hospital for Queens. Years back, leadership made investments and saw what was happening, so actually supported programs like super utilizer kind of programs, and looking at getting people into housing and getting people food as the answer to our patients who were spending a lot of the money. And why was it so important to them? Again, it's a business decision that was made, and the business decision was made that we're going to get as many capitated value-based contracts as we can, get in the money, and utilize the money to care for people, and that is essentially what we've done. 50% of the hospital's entire revenue now is in value-based contracts. Most of it is in Medicaid managed care plans. And we have shown that by this model, you can take care of people if you have a devoted group of folks that want to work together. And especially if you use data, what Dr. Brenner was doing, so it's exactly like the same. So we're utilizing data to identify our high-risk patients, and to identify our high-risk patients before they come to high utilizers, identify them when they're well, and address their entire medical needs and what I'll now call their social risk factors. I'll hand it over to Scott to kind of talk about the model.
Yeah, so I'm just going to run through the model real quickly, but before I do, the question is, does it work or not? This is the 5th time that Mike Tuggy, who's not here today, and I have done this, but it's the first time we've actually had all of the data on all of the utilization. So we always knew we were kind of increasing the process metrics and we were increasing the value-based metrics, but we didn't really know what the total cost of care was. But so it's been such a gift. So you can see back in the first quarter of 2023, when this program went live, the PMPY, per member per year cost for this blended group of Medicaid and Medicare, primarily Medicaid, was $51.02. And then what we see for this population, this is 37,000 people that we ran a pilot on. They have 180,000. This is the 37,000 of them. We saw the PMPY go down to $4,900, In the second quarter, third quarter, 4,900, 4,800 in Q4, and now it's at the end of Q2, it's $4,600. And so we were stunned by this. I mean, we had kind of said to their leadership, it'll take 18 months, it'll take 18 months, it'll take 18 months. And this is far, far more than we ever dreamt of. So there are 5 steps to this, and for the sake of time, I'm going to go very quickly. But the first step is it starts with changing the mindset of the community that's caring for the folks. And this is a step that everybody wants to step over because it's soft science, it's not hard. The second thing is data integration. Third is the clinic structure and flow. And I have to tell you, part of the reason it's so successful is these guys right here. I mean, not part, 98% of why it's successful are these 2 guys. Because it's like, we're going to do this, and how do we do this effectively? And so I hope from Gino today, you're going to hear about literally how you take a group of clinicians and get them all pulling on the same rope and with the administration to make all that happen. And Alan is the leader that without it, nothing would have happened. He is the visionary. The fourth thing is the system support. And the point here is that inside this clinic, you can do a certain number of things, but they are landlocked, very geographically limited, and they're resource limited. So the question becomes, what can you build around them that will actually support them in the clinics? And this is not specialty care. This is primary care that's integrated and expanded. Hopefully next year, Larry, we can get the RIPID group to come talk about this system, because they have probably the best in the country I've ever seen. And then finally, the pathways of care and the vertical integration with specialists. So those are the 5 steps, and to be honest, we are in the middle of 4 right now after 3 years. Which, so as far as the mindset, Gino, do you want to comment on a little bit about, we started, you know, when people are as busy as folks are at Jamaica, you'd go to them and say, we're going to institute change. And they're like, get the F out of my face. I have more work to do. I have 18 hours of work. I'm trying to get it done in 16 so I actually see my family occasionally. Go away. And so, you know, the parable of the cup where a guy goes to Japan to meet his sensei that he's always wanted to meet, and he's so busy talking, the sensei pours hot tea for him, and it goes over the cup and onto his feet and burns his feet. He's like, why did you do that? He said, it's time for you to leave because you have no room to learn. You're filled up, and until you have room to learn, I'm not spending my time with you. And when we first walked into the centers, there were lines out the door, people were overwhelmed, there was no room to learn. So we had to start by emptying the cup a little bit, and we did a program called the Art of Medical Leadership, and we also had people get very excited, so we tried to inoculate them with the fact that, hey, we're excited, we're walking out that door and you're going back into your old ecosystem, and it's going to be very challenging to maintain that excitement. So do you have any comments or thoughts?
One of the things that we tried to do is do this in we have 10 centers around the Queens, Brooklyn area. We picked one to use it as a pilot. A, because it was either easier to control than 10 centers with 40 doctors and all the nursing staff. So what we did is pick one and really spent a lot of time with that center. And then we use the providers and the nurses as our infomercials and advertisement. And they were like, the one comment that I love from one of our providers was the following. He goes, you know what, guys? After all these years, I finally got off the hamster wheel. Because again, all they were doing was the same thing. You come in, your hemoglobin A1C is elevated, I'm increasing your insulin, don't eat this. They walk away because they didn't have enough time to talk about anything else. They come back 3 months later, your hemoglobin, and they were like, this is just not working. We need to really figure out a way to do this. And as we moved along, and we'll talk about that further, that's what really enticed the other people, because they were hearing not me or Scott or Alan, but they heard their own colleagues. So nurses were hearing nurses, doctors were hearing doctors, and we'll talk a little bit about it. Part of our team that was really important is, which is our patient navigators, who have been like literally the forklifts of this program.
Yeah. Do you want to make a comment or go on?
So the navigators we use, we hire people from the community that speak the languages of the patients, and there is no training requirement besides a high school diploma that they have to have, so they don't have to have any medical training. We train them in various techniques and things, and it's more the provider that they work with teaches them what the needs are for the patient and how they can best help the provider. So the provider now has an arm that deals with all the health-related social needs, and we think that's the main reason why we're making an impact.
Yeah, one of the things, Jeffrey, that is really clear to me as a person who's kind of been involved in Medicare Advantage since 2006 is that effective healthcare is a social model. It's not a medical model. That completely misses the mark. And the people who do well are the ones that inculcate the social risk, the health risk into it. So the second thing was data integration. And to go very quickly, so in my experience, this is, and again, 2006, I built the model for that group, and we were very, very successful. Blue Cross Blue Shield had the data, we didn't, and they kind of told us how successful we were. And so this was rebuilding it in 2018 to do this. And there are three questions that have to be answered. Is what are the medical issues and how sick are the folks? But we also inculcate that the complexity of care, the social determinants to the degree we can take it, we get it from University of Wisconsin by zip code, and we can look at where they are. But frankly, in this area, they all have tremendous social determinant needs. And then other demographics. The second question is how well are they being cared for? Given those problems, are they getting excellent care or not? We all think about gaps in care as one aspect of that. The way that we've come to think of it, what Jeffrey was saying, is there's a yellow brick road, which is appropriate care, and there's one ditch called too much care and another ditch called not enough care. And you're trying to get people onto that yellow brick road, and you don't know which side of that. In fact, one person will often be on both sides of it at the same time. I'll just quickly say that there's a large convenience store chain in the United States that the average person makes about $28,000 to $30,000. They're Medicaid, but they all have this private insurance that are high deductible that nobody can use. And so they hired me as their physician executive, and we have gone and redesigned their health benefits, and I'll tell you about those in 2 years, because we've thrown it out the door. The United Healthcare garbage, we threw it all out. We started with how do we remove barriers, how do we get people access to care, how do we make sure everybody's got a primary care doctor and an advocate, kind of the navigator model that they've talked about here, a navigator model, it's a distant model. But the third and the most important thing, and this is something that, Gino, if you'll talk about just for a second, because it's the most confusing to clinicians, is how well is that person engaging in their own care? And so and by the way, there's about 320 variables that we look at, and 120 of them is just this one, and it's asking how well do people engage in their own care. And it actually is the best predictor of a future catastrophic event. You can have people like, let's suppose that I'm obese, diabetic, and I'm on 7 medicines, but I go to my doctor every 3 months, my hemoglobin A1C is 6.5, and my blood pressure is well controlled. Or I could be the same person living under a bridge at the same age, and obviously there's just a huge difference in how well we're going to do. And the amount of work it's going to take to get us under control is very different. So we do this, so what we do is we build a digital twin, if you will, of this human being, and we ask the question, what would serve that person the best? And would this intervention, that intervention, this intervention, and the way that we look at it is what would reduce their health risk score, their total score the most. And guess what it is 98% of the time? Effective primary care. It's effective primary care. So that's the model that we had built. Do you want to comment on the FLAIR risk score?
Yeah, well, again, being a capitated organization that takes full risk, once a patient leaves our network, 2 things happen. 1, we lose money. And 2, we have patients who get 3 CAT scans because they go to 3 different places for headaches. And besides glowing in the dark, they're really not doing much. Nobody's done anything for their headaches. That probably didn't need a CAT scan to start off with. So we're trying to educate our patients when they come in. We know you. We know how to care for you. The patients themselves have the card with the number of the navigator. So they don't have to go through an operator or anything to get to the centers. They can call that person and they will speak to that person. That person will then pass the message off to their doctor. The doctor will then say, okay, there's something I need to take care of, I'll call him back. Or here's the message. The great thing about it is patients have sort of, connected this navigator and me, the doctor. So when they hear the patient, the navigator speaking, they say to themselves, oh, Dr. Tullo said, don't go to the emergency, this is okay, come in tomorrow, I have something open for you. Great, I'm not going anywhere. So what we're trying to do is really, A, bring them in, because I always tell people, in the capitated system, saving money really is keeping your patients healthy. Because they're not going to emergency rooms, they're not getting admitted. And what we've really done is put a lot of work on this, trying to get the patients to come back to us to say, oh, because we know we can treat them, because we know them, and they trust us. So, again, they go to an urgent center for ear pain. If they came to me and said, no, this is TMJ, you don't need an antibiotic, that's fine. The urgent center, most of them hand them an antibiotic and get them out of the office in 3 minutes. So, again, that's not what we want. So that's what we've been working on. I think it's really been very happy. And we've moved away from reactive to proactive. In other words, we don't wait for the person to get sick. We wait for them to come. We call them. We get our navigators to call them and say, listen, you haven't seen Dr. Tullo in 3 months. Come on in, we need to see you.
Yep, and so we're going to come to that in just a second, more detail. But the first thing that we did is put this risk score inside the chart, and now when everybody in the team looks at that, they put their arrow over that red. In this example, this is a high-risk person. Over that, there's 7 scores that come up, and those 3 scores I just talked about come up. So how much is their medical burden that they need to be taken care of? How well are they being cared for? Which is something that the clinicians can really do a lot about. But the third part of it is how well is that person gauging their health, their flare risk, is something that we don't take into account often. And really, it's not often the doctor that needs to do it, it's that navigator. It's putting that into place, or getting a social worker involved, or getting an emotional health system involved, which takes it off of the doctor and puts it, or the clinician, and puts it onto the team, which they are excited about. So the second thing is we had to integrate the data. The third thing is we had to look at the clinical, and this is what Gino was just describing. So every person in the system, one at a time, has a risk, because you do population health one person at a time, as Jeffrey said. And so every person has a score, and so they have teams of people either external to the clinic, or if the clinic has any bandwidth, they are doing calls based upon who needs to be seen first.
Yeah, we have 2 sets of navigators. One are we call provider navigators that are working directly, making sure the patients are getting appointments, or the conduit between them. But then we have what we call outreach navigators. They're a team, they're based outside of the center, and they'll call up patients, and they'll go through a list of each doctor and say, look, this person's 135 risk score, and they start calling to get them in to do what I think Scott's going to talk about.
So here we go. Then the in-office flow. So this is something that they already had done a ton of work. There are patient-centered medical homes, but each visit was choreographed, just like a dance. And so everybody on the team had their part of the dance, and it really works well. And the handoff to the navigator at the end was the thing that has been really reinforced, particularly in the setting of what we call a high-value visit. And the high-value visit's kind of magical. Would you share with them a little
So
bit?
when a patient comes, usually our system was 20 minutes, 20 minutes, 20 minutes, 20 minutes. And what we did was we extended in these high-risk patients and gave the providers 40 minutes to do a lot of things. One, understand what the patient understands or doesn't understand about their illness. Take a look at what the health-related social needs that are impacting them. See what the obstacles to care could be. I can't get fresh fruit. I can't get vegetables. So doing that and asking those questions and building what we call a health plan, a care plan for that patient, so that when anyone who touches the chart, and if anyone uses Epic, we use it through a problem-based documentation. So therefore, you can go to diabetes and see what's the plan for the diabetes. And we have our care transition people calling these patients and following up, because I've started insulin and now I'm going to titrate up. So what we're having the providers do is really set this plan so that other people, not the provider necessarily, needs to carry through on, did you check your blood pressure, did you do this?
Right, so that is the 4th step, which is a post-visit navigation, and this person literally has their plan, and they are literally working with them to make sure they get the care they needed. And that's what he was talking about with the provider. Said, I've gone from Groundhog Day to actually being a healthcare provider.
And it's by decanting the sites we've been able to expand the time. So those follow-up visits that might have just needed an A1C or a blood pressure or some sort of social intervention, we can now do it virtually or with the non-physician provider of the care. So they now took away a 20-minute visit and added another high-value visit.
So to just give you some quick, so the other thing that we did is we created all these dashboards so that actually Gino and his population health group can get very specific with the clinicians about how they're performing and how their teams are performing. And the ideal model that we're working toward is they'll have team meetings where they get to see how they're doing and then kind of healthily compete with each other. And each of these lines is a clinician in the group, and this is the percentage of their high-risk patients that are seen. So the good news is some have gotten up to in the mid-70s. The bad news is some are still hanging out down here at the 40s. And it's not really the clinicians. Clinicians aren't going to get on the phone and start calling people, but it's the effectiveness of the teams and the perceived value of the people. And so when they look at, clinician 9 looks at it and says, ooh, I'm like the worst in the entire group. Next thing you know, they're saying, how do we do this? And they're saying to their office manager, hey, can we get better at this? Because this is embarrassing. They don't know each other's names, but they definitely figure it out. So the next thing is how many high-value visits do people have? And you can see this is the pilot that Gino talked about. And we were doing about 100 a month. And then we opened it up to everybody and the other centers. And we had a really nice 641 people. But here's that J curve, right? It gets fatiguing, get tired, they go back to the old things, they don't really continue to pay attention. So this is where Gino and the other people, James and the other people on their team had to go back out and reinvigorate everybody, and now we've had it come back up and we're averaging about 500 a month. And so that gets us to about half of where we need to be. You can see that the distribution across how many people have had a high value visit, we're at 31%. But we've got people that are, nearly 15% and people that are 12%. And so again, this is where, Big Brother can't come beat people up. You need people to actually just healthily compete. And, people are dying in this person's practice that could have been cared for. And these people are really doing a great job. So So I wanted to show you, here are the 3 risk things. And I did just 2 quick case studies. Here's a 62-year-old with schizoaffective disorder. And you can see that when he first joins the program, his risk score is above 100, but he's not, and he's spending a ton of money. This is actually not when he joined. This is when his first interaction with the healthcare system was. He's spending a tremendous amount of money, but then he's spending nothing because he's getting no care. And then he gets engaged. So here they called him up, they asked him to come in. One of the doctors did an amazing job of getting him in and getting him taken care of. They started to set up these telemedicine visits with psychiatry, here's sleep medicine, and then the primary care. And what we see is that the cost and the, I'm going to go quickly through this. The cost and his spend went down nicely, but we still have challenges. So we're taking it one step at a time, and we make a huge difference to a lot of people like this. So here's another person. This is a person who is getting a prescription that costs $120,000. Seeing a doctor, an infectious disease doctor, has nothing to do with medicines. And so that outreach team that he talked about is calling. And when he needs primary care, he goes to the emergency room. And so this is a person who's spending $120,000 on a medicine that you could easily buy for $55,000 and not compromise care, and was refusing to come see them. So this is a person that then they work with the insurance company and get him assigned to the system where he's actually getting care. And they can then do something about it, because there's no relationship here. There's no ability to change the outcome. And so that's another kind of thing that we're doing. So if you look at the high value visits, you can see that the high value visits per quarter, 15, 13, 9, that was the J curve. Now it's come back up. We're at 15, 39. If we get to 3,000, we're there. That's where so all the clinicians are doing 1 a day right now. And with his new population health initiatives, the goal is to get to 2 a day. And if we do that, they'll win. So I don't have time to go over this with any detail. So let me just show you, look at this number, 28,874 in 1951 with, and the difference between this high-risk, low-cost person and a high-risk, high-cost is going to be $26,000. So what's happening is we're focusing on these folks, getting them in, getting them cared for, and we're seeing this reduction in the number of people. So we want to get them down, we want to lower their health risk. So here's where we were in February of 2023, 13.6% up here at $28,800. And we had 35% at $2,000. Let's go to May 2024, and what you see is this has dropped down, and the cost has dropped down, and the cost down here has dropped down too. So you do the math on this, it's pretty simple. There's 1.26% difference, 473. That's 26,000 times 473. And what you see in that is that the savings, oh goodness, it's $12 million. Okay, then you take the people, now once you get them in your system and you're actually directing them, we saw a $3 million decrease in just people going to other systems. So you put that all together and there's a $17 million total savings. ED utilization, you want to make a comment on
Yeah,
this?
sure. So we, since 6/22 when we first started, there's been a 13% reduction on the total number of ER visits and so a total number of 11% over just the last 12 months. It was closer to about 20% since we started on inpatient days. So again, that means the patients are staying healthier, they're not using those parts of the system, we're keeping them well, and of course, like I said, because it's important in a safety net hospital, we're saving money here, we're saving money on their care.
So here's the total cost of care, 51 to 46, 37,000 people, and 31% of them having high-value visit. And it turns out the majority of this, like 90% of the savings is that's $17 million of savings.
But the key thing is that EMR, for anyone who doesn't know, that's excess medical revenue, that's we get paid this much, we spend this much. Over the past 3 years has gone from $49 million to $118 million. And again, for a safety net hospital, that's really, really important since a lot of our patients we don't get paid at all for what we do.
Yeah.
So
And these are all lagging indicators. So this is not what we're managing, right? We don't have programs to decrease ER visit. We have programs to increase the primary care to reduce health risk. And as a result, those are the lagging indicators. The last things I'll just say is the system support, we're about halfway through that. And then all the integration, we really start working on this next year. So in summary, it's been a very, very exciting, I think that unlike Jeffrey, the experience you had with that double-blind study, we didn't really know how well this was going to work because we'd never had data on total cost of care, and it far exceeds anything that we could have imagined. Any final thoughts or comments?
It turns
Larry
out,
wants to kick us away.
All right.
it turns out that family medicine primary care works when properly structured and funded.
A word of caution, though, is that, first of all, great leadership. They did 99% of the work. I did 99% of the talking. There's something not right about that. The thing is that it's great leadership, and the only way that this works, and this is my big concern about direct primary care, is when you get to share in the savings up here. Just getting paid the same amount down here, you're still going to be working very, very hard. And the DPC population wants to get their active panels down to 500 or 700. You're going to starve to death if you're not careful because you're not getting the value you're creating. And we've got to have a system where for every dollar that's spent additional down here and $3 come off up here, there's a way to share that. And I'm really worried about direct primary care because a lot of them are just like, no, we just want to get paid a set amount every month. And it's like, guys, you're leaving it all on the table. You're leaving the real value of what you're doing on the table. And you can't get to a panel of 500 and expect to make a living. It's not going to happen. You can, but then now you're charging 3 times as much as a company's usually paying for primary care. So the marketplace is very small.